Good afternoon and welcome to the Senior Hour, which is sponsored by Providence Holy Cross Medical Center, IMAC Med Spa, and Comfort Keepers in Home Care. I'm Barbara Cochran with my co-host,
Dr. Thomas Polucki.
On your hometown station, 98.1 FM, AM 1220 KHTS. This is a show for, about, and by seniors, giving information to enhance one's quality of life. And our guest this morning is Sondra Wollenman. She's a nurse practitioner, and she works in the palliative care area at Providence Holy Cross. Nice to see you.
Hello. Thank you so much for having me.
Yes. Now, how long have you worked in this field?
Sure. So I'll give you a little bit of background about myself. So I'm a nurse practitioner. That is a registered nurse who has been master's prepared to be able to assess and treat, diagnose and manage acute illness in patients. I'm specifically trained in the adult area. I worked as a registered nurse in the area of oncology for about 10 years before becoming a nurse practitioner. Through that work, caring for patients with cancer from diagnosis to death, I saw that those patients specifically needed a lot of support and care, which is not always given. They really needed to have goals of care conversations and more specific care. So I decided to go into palliative care when I became a nurse practitioner, and I've been working in the inpatient area of palliative care at Providence Holy Cross for 4 years now. So I did start as a new grad nurse practitioner. I've been there with Dr. Kalani and the palliative care team for 4 years.
Wow, 4 years.
Yes.
Jiminy Christmas. And you say you mentioned masters in there. What is that master's degree?
Correct.
Okay.
Correct. So in nursing, you get a bachelor's degree to be a registered nurse. And then if you want to go on to be a nurse practitioner, you have to obtain a master's degree. I went to UCLA and got my master's degree. And when you're a nurse practitioner, you are now functioning above a registered nurse and below a physician. So you're at the same level as a physician's assistant, and you are now able to diagnose, treat, and manage acute illness in patients. So that's what I do now.
Oh.
But from the nursing perspective, so always with a holistic view, and we always work under a physician.
Oh, that's interesting. Well, I've beaten cancer twice myself. I got it when I was 75, and then I got it when I was 85.
Wow.
And Dr. Black from UCLA.
Oh, cool.
He's my doctor.
Oh, awesome.
So neat guy, really.
Oh, yeah.
Very caring man.
Yeah.
Yeah, he really is. So,
That's great.
Well, that's interesting. So what made you decide to go into this field?
Sure. So when I was, a nurse at the bedside, I worked at USC on the medical oncology ward, and I saw a lot of patients that we were continuing to treat and that were suffering, and that we really didn't have a lot of conversation around what the big picture was in their care. And what the different options were for their care. So I saw a need there. And that really inspired me to become a nurse practitioner and to get into this area so I could work with patients, so I could communicate with patients and families and discuss their different treatment options and really give them the power back to be able to make informed decisions about their medical care. That's why I love palliative, because we really meet patients where they're at and just educate them about what's going on with them and their medical care, and really get to the bottom of who they are and what they want for their life, and then give them those different options so they can make informed decisions about their medical care and about their life. So that kind of inspired me being in that area of oncology. And now, I still work with oncology patients, but we work with all types of patients that have serious or chronic illness, from oncology to dementia to, accidents that happen. We're also a trauma service at the hospital, to stroke patients, patients with liver failure or kidney failure. So you really get to work with all different types of patients and families, and no two patients you treat the same, because of course everyone's different and everyone wants something different for their life. So keeps us on our toes.
Boy, I'd say on your tiptoes.
Yeah. So, Sandra?
Sondra. Yeah.
Sondra, first of all, thank you, because
Sure.
I know firsthand that nurses are the heart of the healthcare system.
Thank you.
I was raised by a nurse. So,
Cool.
yeah, it's kind of the family business, and it strongly influenced my life, and I know how hard the job is.
Yeah.
I've seen it firsthand. It's it is definitely a calling, and I get it. But before meeting Dr. Kalani, I had a prejudice about palliative care, which I believe a lot of people do. A lot of people have a misunderstanding about palliative care. They hear the word and immediately they think, angel of death. Like this is the end game. This is, there's nothing else that can be done, and we're just putting you out of your misery.
Right.
So if we can just touch base on that a little bit, because
Sure.
I think it's important that people understand that when they hear that, it's not what most people think.
Sure. Yeah. So there's a difference between palliative care and hospice care, and that's something that we educate people on quite frequently. So palliative care is really any patient that has a serious illness or a chronic illness that really needs that extra layer of support and that whole person care. So anyone can receive palliative care that has a serious illness, even if it's at the beginning of that illness. So we see patients from diagnosis and then all the way up to when they're transitioning to hospice care. So hospice care is different because palliative care is a medical specialty. We follow along with all the other medical specialties, and the goal is really for aggressive treatments and treating that illness with the goal to, treat that disease. When you transition over to hospice, now the goal has changed. It's still supportive care, but now the goal is really end of life care, and the goal is for comfort. So you're no longer getting any aggressive treatments, and now you're just going to focus on pain and symptom management. So that's the main difference. And really, we're a newer medical specialty, been around for like 20 so years. And there's been studies that have shown, there's one study that looked at lung cancer patients, and they followed two groups of patients. One received palliative care with standard of care treatment, and the other one received just standard of care treatment. And we saw that those patients that received palliative care actually lived longer than the other group. And that's because we focused on who they were, their quality of life, and their symptom management. So our goal is really to provide quality of life and listen to patients and meet them where they're at in, their disease trajectory. So,
yeah, it to me, and I'm sorry, playing devil's advocate
please,
here.
yeah.
It's a shame that there has to be a specialty
I know.
in healthcare
I know.
that it takes it up a notch and gives the patient that kind of care, because you'd like to think that all of healthcare is that.
Unfortunately, the way that our medical system is, physicians are trained and specialized in certain areas, which is great because you get specialty care, but then a lot of physicians are looking at only their specific area. The kidney doctor's looking at the kidneys, the lung doctor's looking at the lungs, the heart doctor's looking at the heart. And then a lot of times you don't have a physician or a medical specialty that's looking at everything, looking
Right.
at the whole person and really talking to the patient about, what the big picture is.
Right.
So that's where our medical specialty came in. And it's a beautiful thing because you see that patients really do benefit from our services because they're able to make more informed decisions about where they're at and what the different medical treatments mean for their life.
Right. So there is a whole postgraduate
Yes.
certification
Right.
in palliative care.
Yeah.
And so you're a nurse practitioner. Were you a nurse practitioner before you got specialized in palliative care, or was it the other way around?
Yeah. So my specific degree is in adult acute care. So I've been trained to care for adults that are acutely ill. So that's a broad, range of different areas that you can go into. Then I started in palliative care, and I actually got certified as a nurse practitioner in palliative care. So I was first in NP, and then secondarily, I got a certification in palliative care.
Got it.
It's interesting because Russ was in Henry Mayo for 5 weeks. And he went in there initially with COPD and he got pneumonia. And the doctor put him in Henry Mayo. And he was being treated
Right.
normally for that kind of thing.
Right.
And then he got worse. And the doctor wanted to put him in an acute care facility.
Okay.
And he said, absolutely not. I'm not going there. I'm either going home or I'm staying here. And we decided he needed to stay there because of the care he was getting.
Right.
So then eventually it went into palliative care.
Yeah.
And then finally the doctor said, he's not going home. So let's bring in hospice care. And so we went through those levels
Right.
with people coming into the hospital because I said, he doesn't want to go into a home. He has absolutely no, and he always said that. He never wanted to be put in a nursing home.
Right.
Right.
Yeah. I get
And but he was better in the hospital because there was immediate care right there if and when he needed it. And he needed it quite often because he was having he had to have internal stuff you put in your body to
Right.
Ports.
liquid
A line.
whatever it is, keep your body wet inside.
Oh, hydration.
Right.
Hydration, thank you. That happens as you get older. Your mind kind of goes,
Forget the word. Yeah.
See you later.
Syllables.
Yeah.
Not a movie.
Yeah.
But that they had to do all of those things, and there was
Right.
no way
Yeah.
that it could be done at home. Absolutely no way at all.
Yeah.
And so he stayed there, and everybody said they let him stay there, and I had to pull a few strings.
Sure.
Yeah.
Yeah.
Being a community volunteer and
Right.
knowing a lot of people, I was able to say, hey,
Yeah.
this, and Russ was too. He was involved in the community. So I usually don't tell that to many people, but,
Yeah. In that case.
I needed to do it.
Mm-hmm.
I absolutely
Yeah.
needed to do it.
Advocate for him.
And that's what I did. And he passed away at Henry Mayo.
Oh.
But he was under hospice care at that time.
Right.
And the hospital provided that.
Oh, good.
So, which was nice.
Yeah.
And it was really helpful, even though I had really known what was going on. I did a lot of research myself,
Yeah.
And of course, having what they were saying to me further enhanced my understanding of what was happening.
Right.
And I knew that he did not want to go home and didn't want to go into the nursing home.
Right.
So
Oh, good.
So, but he's in a better place now. Bless his heart.
So, Barb, that's your experience with palliative transition into hospice, but does that sound pretty much like a typical situation for you, or is every single situation unique? And what do people need to know about that whole thing
Yeah.
instead of finding out,
Yeah.
like when it's really happening?
Right. So that does happen sometimes where we get a little bit of a late referral and we pretty much have to meet patients and then almost immediately transition into hospice. We do always recommend an early referral to palliative when they are still receiving aggressive treatments, but they have a serious illness and they could just use our support. So that's always the best case scenario because we get in when they have a chronic illness or a serious illness. We can start building that rapport and that relationship. We can talk about who they are as a person. We could talk about advanced care planning, which means like advanced directives and pulse and who they would want to make their medical decisions and what their medical decisions would be for the future. It's always a little bit better to get consulted pretty early because then you could really develop that relationship. You could set them up for home-based palliative care because they're probably going to go home and they're going to be continuing to receive aggressive treatments, for a while until eventually they transition to hospice. That's always the best case scenario because, like I said, you develop a relationship and you can really support people. And then it's not so scary when you do have to have that conversation about a transition to hospice because you already have a relationship with them. But we do see, all stages of disease getting consulted. And, as the word about palliative care gets out more, we do get more and more early consults, which is really the best because, like I said, then you can, come in when you're kind of in the background. All the other physicians are more in the foreground because the goal is really for aggressive treatment. You're just kind of in the background supporting. And then as the disease goes on, you become more and more present as, things start declining more and more.
Is there a set trigger point or it's at the primary physician's discretion? And, how is this all worked out? Because it sounds like, there's too many things that could potentially fall through the gaps there.
So it's really about relationships, in all honesty. Different hospitals, you'll see different things. We're really dialed in at Providence Holy Cross. We've made relationships with every single one of the medical specialties and the physicians. They know that we're there to support them. We're not coming in with any type of agenda. We're not trying to just place their patients on hospice care. We're really there to support them and support the patients. So I would say at every hospital, it might be a little bit different based on how present palliative care is in that institution and the relationships that have been made with all the different medical specialties, because it is based on a physician's order.
Right.
Well, now, do you visit homes? Do you go to personal homes?
We do. So we're just in the hospital, but we do have a home-based palliative care that is with Providence. That's a group that does visit patients in the home and, is there for patients to support them in the home.
I see.
Yeah, so there is a home-based group as well. And we refer to them when a patient's discharged from the hospital.
And so they're able to visit the home.
Correct. Yeah. And they have a doctor, they have nurse practitioner, nurses, social workers, chaplains, everything like that.
The whole thing.
Mm-hmm. Yep.
Oh, that's good.
Yes, it is good.
Because that's what I'll get when my time comes.
Yeah. And then they follow along and continue to discuss goals as the disease progresses, and they can even transition to hospice when it's appropriate.
Interesting.
And I hear this question far too often. I don't know how relevant it is for someone who works almost exclusively in the hospital, but I hear it almost every day. Is it covered? Is palliative care covered the same way that whatever they're there for would be covered?
So we hope so.
Right.
Insurance is definitely moving towards more coverage of palliative care in the community because they're seeing the benefit. Patients are staying out of the hospital because they're getting more support. They're getting more symptom management. So more and more it is being covered. But that is something that when we put in the order, they'll run insurance. Certain medical groups have their own group that they work with. So yeah, more and more we are seeing it covered. And I think we'll continue to see more coverage as the years goes by because of the fiscal benefit of it.
Awesome. Thank you so much. We'll be back with more on palliative care. You're listening to the Senior Hour at KHTS 98.1 FM, AM 1220, hometownstation.com.
Welcome back to the Senior Hour. I'm Barbara Cochran with my co-host, Dr. Thomas Polucki, on your hometown station, 98.1 FM, AM 1220, KHTS. And we're speaking with Sondra Wollenman, who is a nurse practitioner, and she works in the palliative care area in Providence, Holy Cross. And my goodness, have we covered a lot of information.
Oh, thank you. Yeah.
So,
And Tom, you had something you wanted to talk further about?
oh, yeah, sure. Why not?
Go for it, kid.
Just a quick recap. First of all,
Sure.
I love Providence Holy Cross. I mean, they really are setting the standard. I know there's a joint effort with Cedars happening out over by Woodland Hills, yes?
Yeah, with Tarzana. So yeah, the Tarzana folks are partnering with Cedars.
So is that up and running yet?
Yes, I believe so. And we partner at Providence Holy Cross with City of Hope. So that's,
Gotcha.
yeah.
Okay, yeah, nice relationship there. And second of all, just an acknowledgement of nurses in general. I was raised by a nurse, and I understand the challenges that nurses face. They are definitely the heart of the healthcare system.
Thank you.
They're the hardest working entity in the healthcare system, and they really. My experience is that nurses have always been palliative care.
Yes.
They are the example of what doctors should be like with their patients. And unfortunately, doctors don't always have the time to do that. They have to, do their job, get in and get out and get on to the next. But nurses are there, have a much more lengthy and deeper relationship with the patients, and it can be really hard on the nurse at times. So before we get into the differences of palliative care and what that really means, because a lot of people don't necessarily know, what kind of protective measures do you take? Because I know you get involved with your patients, and not all of them are going to make it through. Right, so what is your it's called professional detachment, but I know nurses are subject to more stress than doctors are when it comes to this stuff.
So there's more interaction. Much more.
Yeah.
It's a different relationship.
Absolutely, because you're in the doctor's office and you're out.
Right.
You're in and you're out. What, 10 minutes sometimes? How are you doing today? Oh, I'm fine. Goodbye. See you next month.
Right.
And that's what the doctor's offices are like, with few exceptions.
Yeah, it's true. I mean, I had to figure this out early on, and I think every nurse has to figure this out early on because you are at their bedside for 12 hours a day. And if, the majority of areas in the hospital are high stress, you're, with patients and families on the worst days of their life in the worst situations. So you do have to find a way to realize that it's not your responsibility what happens to this person, but it is on you to help guide them through. So when I realized that it wasn't my, fault or what was going on with them medically, but it's just my job to help guide them through, and kind of made that detachment, that helped quite a bit. And you have to do that pretty early on in oncology because you're seeing a lot of pain and suffering. And it's not something that a normal human being is ever exposed to.
Right.
So it really does feel very heavy. And then also realizing that some patients are just going to hit you harder than other patients. You are going to develop a relationship. You are going to feel more for certain people because of maybe your background. They might remind you of someone, or you might just really like this person, and it's okay to feel that. In fact, I think it means that you did your job well. It's okay to go home and cry. It's okay to feel that for a moment and then to, pick up the next day. For me, I really work on, leaving my job at my job for the majority of times, and then really working on being present with the people in my life and making sure that I have stable, good people in my life, and really trying to be present with my family and taking the time with them. So that's kind of how I take care of myself.
Yeah.
Well, you have to because of the ages of your two children too.
Yeah. Yeah.
Because they need mom.
Yeah.
And
Yes.
if you're working 24/7,
Yeah.
they
Yeah.
won't have mom.
Right.
And you're a crucial part of their life at this point, because
Exactly.
they're beginning to look around and see things. Oh,
Yeah.
really? That?
Yeah.
What's that, Mom?
Yeah.
What does that mean?
Yeah.
And they're going to be getting older and older and asking more questions. So who takes care of your family while you work?
Yeah. So my parents, I'm very lucky to have, two parents, their grandparents that are very involved. So my mom took care of them up until they were 2 years old, and then they went into preschool. So they're at preschool now. So they're doing their own schooling, which is good.
Oh, well, that helps.
Yeah. So that's a good thing.
And not that it matters, I'm just curious. What is your shift?
Yeah. So now that I'm a nurse practitioner, I work Monday through Thursday and 10-hour days. So I come in the morning and, more or less normal hours during the day.
No such thing for a nurse. There are
10
no normal.
hours?
Yeah.
That's not normal hours. That's above and beyond. But at least you have more days at home.
Yes. I always have Friday, Saturday, Sunday off, which is nice to be with my
Yes.
family, which is good.
Yeah.
Yeah.
So what does your husband do?
He works, he's an insurance broker. So he, works for a business,
So
which is
can
nice.
he name his hours also so that he's at home with you all, with the kids?
Yeah. He always has Saturday, Sunday off, which is good.
That's good.
Yeah.
So
yeah.
you are a family unit,
We are. Yeah.
at least for a few days.
Right. But it takes a village with little
yes.
kiddos. So I'm happy to have my parents and my siblings and everything to help out.
Okay, so back to the gorilla in the room. Or elephant. I mix metaphors all the time, and I'm not
Gorilla
even
and
sure what they really
Whoa,
mean.
What a difference.
Palliative care.
Right.
It's like a bombshell. Most people, when they hear that, they're thinking hospice.
Yes, they are.
And there's a big difference between the two. They are related, but they don't mean the same thing. So if you could just compare and contrast them,
Sure.
In everyday terms. So, if someone hears that, they don't immediately jump to, oh, well, that's end of life care.
Right. So the philosophy is the same, being like whole person care, symptom management, that type of thing. But palliative care is really when a patient's main goal is for aggressive treatments. They have a chronic or serious illness that they need really whole person care. They really need symptom management and support, but the goal is still for aggressive treatment. So we're a medical specialty, like any medical specialty, like nephrology, nephrology for the kidneys or cardiology for the heart. So we come in as a medical specialty, not the primary specialty, a medical specialty to provide support. And then at some point when treatment options are limited and there's really no aggressive treatment options left, or a patient and family desire just to focus on pain and symptom management, comfort and quality of life, and the goal, and that's really the goal at that point, they transition to hospice care. Now, hospice care is, a Medicare benefit. You do need a terminal diagnosis with a life expectancy of 6 months or less. So that's really the difference there. So hospice care is really end of life care, where palliative care is, whole person care that is takes place at any point of illness.
Gotcha. So I just want to clarify one point, because you did make a delineation there about where the cutoff point is for hospice. Medicare kind of sets the standards for many of these coverages as far, and they guide the decision-making process for other forms of insurance as well. So is there any kind of delineation or cutoff point from, I know you're taking care of the people, but as far as, let's just stick with Medicare for a second, because this is the senior hour. Is there any limitation or hurdle or cutoff point or initiation point when it comes to palliative care in the Medicare system?
So for palliative, they just need to have a chronic illness diagnosis.
Well, that's going to be almost everybody.
A lot of diseases, fall under that umbrella. So we really do make the decision about if they're appropriate for palliative care or not. And, for Medicare to cover, you just need that diagnosis. So like heart failure, something like that.
Right.
Cancer.
You work with mainly seniors, don't you?
I mean, we work with a lot of seniors because a lot of disease happens in the later years.
Right.
But we do also, palliative care could be for any person that has a serious illness. So we do, unfortunately, see younger and younger patients with serious cancer diagnoses.
Yeah.
And then also we see a lot of younger patients with some type of, trauma or accident or things like that. So we see a lot of those at the hospital too.
Now, how do you feel about long-term care insurance?
A lot of people don't have it, so I'm not super familiar with the benefit. But that could be a good benefit for people.
Well, it sure was for us.
Yeah. Oh, okay. You probably know more than me.
Oh, well, it was interesting because I heard about long-term care insurance, and I talked to my husband about it. He said, nah. He said, we don't need that. Well, I got it anyway.
Oh, good.
I didn't tell him about it.
Yeah.
Until we actually needed it. And it paid 2/3 of our bill because I had to have 24/7 care for him. So that I could get some rest and get a good night's sleep while he was in the living room, because he couldn't lie down because of back problems and that kind of thing. And of course with the COPD, there was the pneumonia, there was the coughing and the clearing of the throat, that kind of. So he always slept sort of sitting up, in one of those seats that go down, but he was like this. And so I had to have someone come in and take care of him. And it was a blessing.
I will say the
really,
caregiving. The caregiving burden is a lot for people.
It really is. Because
the last few years
I
of
couldn't
life.
possibly do it.
So palliative care crosses beyond the patient into family support, yes?
Correct. Yes.
So can we talk about that
Sure.
just briefly before our next break?
Yes, so we support everyone who is a caregiver for the patient. So whether that be family or whoever, supports the patient. We definitely, one of the questions we ask is about advanced care planning and who they would want their medical decision maker to be in the case that they couldn't make medical decisions for themselves. And then, we support the family. And, if a patient's really chronically ill, sometimes we're just directly communicating only with the family.
Right.
So we do a lot of whole person care and family support as well.
Right. And I don't think we have time to really get into those details because that, I believe, is a very important aspect of what you
Yes.
do. But we've got to take a break. You're listening to the Senior Hour, KHTS, FM 98.1, AM 1220, HometownStation.com.
Cochran with my co-host, Dr. Thomas Polucki, on your hometown station, 98.1 FM, AM 1220, KHTS. And we're speaking with Sondra Wollenman, and she is a nurse practitioner with the palliative care area in Providence, Holy Cross.
Hello.
Yes, and you
Yeah.
had a subject.
So, palliative care has a lot of, as soon as you hear it, you think hospice care, and it's not the same thing.
Right.
Palliative care, well, I'll let you take that, but we've talked a little bit about the machinery, the syntax, how it works in palliative care in the hospital setting. But if we can focus on how that affects the family members, because I know that's a big part of palliative care that really, in my experience, kind of sets it apart in a big way.
Yeah. So, as we've talked about, palliative care is looking at the whole person, and that also involves their family. Palliative care is really meeting the patient and the family where they're at and supporting them in whatever need they need in that moment. So, palliative care is really going to follow along, and specifically with the family, they're going to speak to the family and see, what that patient really needs, outside of the hospital, inside of the hospital, what questions they have, and support them through the disease and treatment processes that they're going through. So a lot of the times we'll refer, so we'll speak to families, we'll refer to social workers so they can get in touch with families to ask about, caregiving resources, different resources for the home. So palliative care is really unique because we work with a whole team of specialties. So, we work with a physician, nurse practitioner, nurses, but we also work with social workers, chaplains. So really we have the ability to speak to patients and families and get them dialed in with whatever service that they need to address their specific need.
Yeah, because it's not just the patient.
No.
Everybody's having a bad day.
Yeah.
And that,
Yeah.
for the patient, at least, they're obviously under the most amount of stress, but they have the care of that hospital setting. The immediate family, however, has to deal with all of that, and then they're just out on their own for the most part.
Yeah, we really want to care for the caregiver because you're right. A lot of times they're forgotten and they're very stressed and they're very overwhelmed and they're really, dealing with this, the weight of the world is on their shoulders. So we really work on, caring for the family unit as well.
That's awesome. So first of all, much respect for nurses in general and palliative care. I think we need to get past the stigma of this is just hospice care in disguise. Like
Right.
It's far from it.
Yeah, it may be the model that all healthcare should follow. At least that's my opinion on it. And then the family support is huge. So is this, you said that it's different from hospital to hospital, and I know you work with Providence, which again, thank you for being our sponsor. Providence Holy Cross is just amazing, and I believe another model of what healthcare should be. So can you, I mean, like in 1 minute, just talk about that for a little bit, like your relationship with Providence Holy Cross.
Yeah. So I think, what we're doing right now is really educating people on the difference between palliative and hospice. And I think it also starts at, the beginning of physicians that are newly being educated, and now they're being educated on the difference between palliative and hospice. So I think as we go forward, we're going to see more hospitals knowing the difference and being able to utilize palliative like we utilize palliative at Providence Holy Cross.
Awesome.
Yeah.
Sondra.
Yeah.
Thank you so much for
Thank
being
you.
our guest on the Senior Hour. You've been listening at KHTS FM 98.1 AM 1220, hometownstation.com. Now go out and enhance your quality of life.